Good evening. In this presentation, our group will present a formal debate on collaborating with other professionals. We will talk about various topics regarding the pros and cons of collaborating with other professionals in relevance to ABA therapy. Throughout this presentation, you will hear a group that is in support of collaborating with other professionals and a second group that is in doubt of collaborating with other professionals. Both groups in the debate will provide information through research and our experience in the field. I'm Maria Repstock. I am the pro stater in this debate. I have been in the field of ABA as an RBT for 6 years, working with children ages 3 to 10 years old. I graduated from Rowan University with a bachelor's degree in psychology, and I'm currently in my 4th semester at Ball State University. I work in a school district that houses an autism program. I float around to each classroom to help implement behavior programs to support staff, observe and collect data, de-escalate behaviors, and train other RBTs in behavior programs, all while reporting back and working closely with the school's BCBA. I strongly believe that collaboration with other professionals is a key component in providing the best outcome in behaviors and success in children with ASD.
Hi, my name is Rachel Gage, and I've been working in the AB field for 3 years and in behavioral health altogether for 5 years, working in residential treatment as well. I completed bachelor's degrees in criminology and sociology at Arkansas State University in 2022, and I'm currently in my 3rd semester at Ball State University. For this debate, I am a con stater as well as a con attacker. As a con stater, I believe that collaboration among other professionals can cause ethical issues and vary in teaching methods, which in turn creates a barrier in progress for clients. And as a con attacker, it's highlighted that the level of effective communication required to adequately provide services under collaboration is difficult to maintain.
Hi, everyone. My name is Bailey Jones, and I have been working in the field of ABA for 2 years, although I have worked with children from ages 2 to 11 on the autism spectrum for about 5 years. I have a bachelor's degree in psychology from the University of Houston, and I am now in my 4th semester at Ball State. I am a pro-prover in this argument, and I believe collaborating with other professionals can not only be effective for the BCBAs and the other professionals, but most importantly, it is imperative in providing efficient care for the children that are receiving the therapy services.
Hello, my name is Heather Sims, and I've been working in the field for 2 years. More recently, I transitioned from providing services in an in-home setting to a clinic setting. Cumulatively, I have about 5 years of experience working with children with disabilities. Currently, I hold a BA in sociology from Hartwick College in New York. This is my 5th semester attending Ball State, pursuing my master's in ABA. In this current debate, I am a con prover highlighting how certain factors in collaborating with other professionals can be problematic or not work efficiently.
Hi, my name is Chelsea Sima, and I have been a special education teacher in the self-contained setting for 10 years now. I have a master's in special education and a bachelor's in communication sciences and disorders. Over the last 7 years, I've been collaborating with BCBAs and RBTs to provide ABA services within the school setting, and I've pushed for effective collaboration between the two entities to ensure the greatest and most effective services are being given to my students. This is my last semester of the ABA graduate certification program at Ball State. And as a pro attacker in this argument, I'm looking forward to continuing with my collaboration in the coming years.
What is professional collaboration? You may be wondering what that means. Professional collaboration is a way of working in partnership that acknowledges the professional expertise of each person involved. Collaboration must utilize effective communication, and it consists of mutual respect in order to achieve a common goal. The professionals involved may include, but is not limited to, BCBAs, speech and language pathologists, occupational therapists, physical therapists, gen ed teachers, and special ed teachers. An example If a child is working on manding with their AAC device with a speech therapist, the child's BCBA would be informed of the child's speech goals with the AAC device to gain insight on the child's skill level. Being given this information, the team is able to achieve the best possible outcomes for the child. On the other hand, the BCBA can provide strategies to the speech therapist to increase motivation, manage behaviors that may occur, and provide effective training techniques that are used in ABA. Collaboration between analysts and various professionals is an essential component in the treatment of individuals with autism. In this argument, we support the need for collaboration between behavior analysts and other various professionals. We believe that ABA services should be accessible to as many professionals as possible to implement effective ABA services. Therefore, having a team of professionals to collaborate together to serve the needs of the client maximizes the client outcome. As BCBAs, it is our duty to collaborate with as many professionals as possible. To support our position in this debate, we will talk about specific points such as professional collaboration, which allows for consistent care of the client. Many children with autism face multiple educational and clinical care systems. Since professionals all practice under different scopes, they must collaborate with those outside of their personal scopes in order to provide sufficient care for their clients.
The position taken by this group is that collaboration between behavior analysts and various professionals can cause ethical issues, they can vary in teaching methods, and cause more risk to progress rather than benefit to the client. As further stated in this argument, there are significant barriers to the success of clients with the ethical issues presented in the collaboration. Some of the ethics codes that highlight these potential concerns are 1.02 Boundaries of Competence, 1.05 Professional and Scientific Relationships, etc. It can become increasingly difficult for behavior analysts to remain practicing within their scope of competence under frequent collaboration, making boundaries of competence unclear. The varying teaching methods are also expressed in this argument as having an effect on client quality of treatment. The controversial collaboration between ABA professionals, SLPs, OT, etc., is discussed as causing some loss in the standard of behavior intervention/therapy.
Ensuring that patients who have been diagnosed with ASD are receiving high-quality care requires that all caregivers, therapists, and teachers collaborate and be effective in their communication. In an article by Gardner et al., the importance of interprofessional collaboration is described as a framework to facilitate increased collaboration between school and clinical providers working with autistic students. The article goes on to note that interprofessional team-based care is defined as care delivered by intentionally created, usually relatively small work groups in healthcare, who are recognized by others, as well as having a collective identity and a shared responsibility for a patient or a group of patients. Collaborations are especially important for students with ASD, as they may face multiple educational and clinical care systems. Both clinical and educational systems offer important services to autistic individuals, but they are significantly different. Collaboration and communication between these two settings are important to provide the best consistent care for these individuals. Teachers, RBTs, SLPs, etc., all practice under different scopes of competencies and cannot cross these boundaries. For this reason, it is important to collaborate and create the best overall care for their clients. By collaborating with other professionals, we can help relieve the already heavily burdened parents by reducing the need for them to have to be a conduit between therapists. According to the BACB Ethics Code, it is the BCBA's responsibility to arrange for appropriate consultation with and referrals to other providers in the best interest of their clients, which is 3.06 of the BACB Ethics Code. This is important because if a client requires speech therapy, occupational therapy, physical therapy, etc., The BCBA must arrange the necessary therapy and collaborate with these professionals to provide the most effective and efficient therapy for their client. Another important code outlined by the BACB is 2.10, which discusses the importance of collaborating with colleagues from their own and other professions in the best interest of their clients and stakeholders. As Rachel stated previously, it can be argued that there can be controversy in collaborating with other professionals, leading to a loss in the standard for behavior intervention therapy. However, this code specifically discusses that the role of the BCBA is to ensure that they are addressing conflicts by compromising when possible and always prioritizing the best interest of their client. This would eliminate the issue of conflict if the BCBA is following their own ethics code. This visual shows that there is not only a separation of scopes of practice and competencies between SLPs and BCBAs, but there is also an overlap in these scopes. Both the separations and overlaps are equally important as they offer opportunities for collaboration as well as growth and room to learn. As stated by the Association for Behavior Analysis International, within this shared space, the potential for perceived and actual encroachment exists, and where skillful collaboration and professional humility are essential.
Collaborating with other professionals can be problematic as a BCBA when serving clients and remaining mindful of the ethics code. Referencing back to the diagram Bailey shared, while there may be an overlap between certain professionals, providing services, when providing services, certain factors definitely serve as a barrier to the actual success. Some of the barriers include, but are not limited to, incompatible goals, the use of non-evidence based practice, and implementation disagreements. Additionally, the evidence for supporting collaboration is currently weak. Behavior analysts are also faced with an ethical dilemma when dealing with professional collaboration. In regards to incompatible goals across professionals, for example, behavior analysts working from a behavioral perspective, while SLPs work from a linguistic or developmental point of view. Trina et al. 2020 highlights that behavior analysts teach communication based on their functions, while SLP does so based on language structure. Trina goes on to say that SLPs teach communication functions, but they differ from definition held by a behavior analyst. The difference in perspectives leaves clients vulnerable to a delay in services or unclear service delivery if professionals cannot come to an agreement, ultimately affecting client goals being achieved. When implementing treatment, behavior analysts strictly try to use evidence-based procedures. Potential conflict in collaboration between professionals exists, specifically between OTs and behavior analysts. While the use of evidence-based practices are stressed as a high need in OT, the push for their use is a newer development, and the lack of focused attention on evidence-based practices does not align with ABA's exclusive attention to them. The following visual provides examples of different non-evidence-based practices and what the risks of utilizing them are. So one that you may have seen is vitamin supplements. Maintaining a healthy, balanced diet is obviously of the utmost importance. As a result, healthcare providers may try to promote the use of nutritional supplements to people with or without autism. Supplements can become problematic as they can be used to be a cure for autism, and there's just currently no scientific evidence supporting that claim. In addition, using these supplements without the consultation of a healthcare professional, which is a risk that can occur, can just be unsafe. Some supplements that are higher doses and taken for a longer period of time, like vitamin A, can be toxic. Additionally, some supplements accurately reflect their claims of what vitamins contain, while others do not. Another non-evidence-based intervention that is seen pretty frequently would be this gluten-free casein diet. And this diet monitors or restricts the gluten/casein intake for individuals with autism. Things that are protein that is found in wheat, rye, and then casein is protein found in dairy products. This claim backs this dietary restriction is that children with autism supposedly have leaky guts, which allow opioids to escape into the bloodstream. Once opioids leak into the bloodstream, they supposedly travel to the brain, causing autistic behaviors. This claim is not evidence-based, and comparatively, studies have found that children with autism do not have more opioids in their blood than that of their typically developing peers. One of the concerns here is that these children on these diets are reported to have a lower bone density than those without these dietary restrictions. And down the road, a long-term potential effect is a diagnosis of osteoporosis. Another con of collaborating with professionals is implementation disagreements across these different professionals. For example, while OTs focus more on the eclectic interventions, BCBAs focus on intensive behavioral treatment. Howard et al. Conducted a study demonstrating that IBTs had more significant improvement than eclectic interventions. An additional example of potential conflict in implementation would be between SLPs and behavior analysts. So prompting varies amongst ABA professionals and SLPs, while BCBAs may use the least intrusive prompts first. An SLP will resort to using the most intrusive prompt when teaching language. For instance, an SLP may use a partial verbal when waiting for a verbal response, while BCBA would resort to the most appropriate, least intrusive prompt first, such as a gestural cue. So attached here to the slide is actually a prompting hierarchy, and it's just showing you where different prompts lay, and it's part of the argument here is just that SLPs are using most intrusives versus BCBAs who are using the least intrusive. And just lastly, as explained by Schroeder et al. 2017, there's just simply not enough evidence to make claims of the benefits of collaboration between professionals, and this is especially seen between OTs and behavior analysts.
So the argument that collaborating with other professionals goes against the ethic code is one that can be twisted to fit the speaker's narrative depending on the information they are looking for. So it's very easy to twist ethics codes to kind of fit your narrative. So the first point to come up to discuss would be the understanding roles in the collaborative situation. So when a behavior analyst collaborates, it's important to know their role in the situation. If they're providing services in a school setting, then they should be deferring to the classroom teacher for the structure of the day, curriculum intervention, and social facilitation. In that school setting, they are strictly there for behavior support. There should be a mutual relationship and understanding between the school professionals and the BCBA that states that when it comes to behavior intervention, the behavior staff takes the lead. But in all other circumstances, that's where the school officials take the lead. The same is said for therapies. If a behavior analyst or RBT is providing support in an outside service facility, such as like an OT office or an SLP office, then they are also only there for behavior intervention, but it's up to them to make sure that they collaborate ahead of time and share those interventions and strategies with the OT while letting the OT do their work in their facility. Likewise, if the support is being provided at an ABA clinic, meaning like the outside service providers are being brought to the clinic to service clients, such as speech or OT, then it is their job to defer to the behavior staff first and foremost and step back when needed because you're in their house, so to speak. In these situations, it's a matter of knowing your scope of competence, being able to communicate about services, collaborating with your colleagues, consulting other providers, and consulting with third-party contracts for services. The next point touches on the evidence-based practices to be used by all team members. So in the previous argument, it was discussed that occasionally not all therapies are using evidence-based practices. But educators, SLPs, OTs, and other related service providers are held to their own sets of standards of performance, which do include evidence-based practices. You can get outliers there, but each different profession has their own evidence-based practices that they follow as well. And like we have touched on already, there is a lot of overlap. When a BCBA goes to another setting, it's up to them to familiarize themselves with the practice of their stakeholders to know what is a typical practice in any environment. And it is up to the BCBA to report or to comment on a practice if they feel like it is not ethical. Simply stating that providers aren't using evidence-based practices because they aren't, say, placing a token on a token board every 2 minutes without a maladaptive behavior is unjust because that provider isn't there for behavior support. The behavior analyst is. The next point on this section would be the implementation fidelity and why there can be a lack of evidence. A lot of the arguments in this is about the fact that there's not a lack of continuing evidence supporting collaboration between other entities and ABA centers and facilities. So ABA, let's see, if you look at the collaboration as an umbrella, such as the graphic that's shown, you'll see that collaboration holds the main components of effective instruction. And just on top is professional development. So picture going to a professional development, sitting through something in any field. You're not going to automatically become an expert in whatever you're learning in that professional development. You're not going to be proficient in the topic that you were instructed on right away. It takes time and practice to learn and hone the new strategies in order to have them be effective within their settings. This is the reason why there is an implementation fidelity gap between ABA providers and places like schools and other service providers. Per an article on board certified behavior analysts and school fidelity of applied behavior analysis services from Max and Lambright in 2021, ABA is based on technical language that can prevent successful implementation when jargon is used without ensuring that all trainees understand the terms being used. Behaviorist perspectives, including the philosophies that underline ABA, are often described as being at odds with a humanistic perspective. This has been cited by some as the primary reason that ABA procedures are not being carried out in schools, as some teachers and parents have preferred more humanistic neurodiverse strategies over ABA. This can be seen in the myth that ABA reinforcement is the same as bribing kids with candy, which is derived from the use of food as a primary reinforcer. While food is sometimes used as reinforcement in ABA, reinforcement is by no means bribery, and we know this, but this would go back to being able to collaborate amongst the settings and explain our reasoning for using food as a reinforcement. The last point in here is regarding the weak evidence to support. So methods to improve the implementation integrity and fidelity of best practices has been widely researched. This is also from the previous article. Using the principles of ABA to teach school staff to use ABA has been proposed by some, like Albright, Colin and Meek et al. In 2017 and 2016, respectively, where they studied the use of ABC procedure to shape implementation of ABA amongst school staff. The results indicated increased successive training with this procedure, although a follow-up was not completed at that time. The Albrecht et al. Found that positive training outcomes with the use of ABA, the ABA process of stimulus equivalents to teach students to correctly identify, graduate students to correctly identify the function of behavior, which we know is a core tenet of ABA. According to recent literature, ABA interventions in schools are often not implemented to fidelity, not due to lack of research, but the current study presents data that describe the reasons for this lack of fidelity as a breakdown on lack of staff training, inadvertent proliferation of myths in ABA, back to the Candida's bribery, staff training, and insufficient resources and buy-in from the administrators. Once these reasons begin to be addressed, collaboration can become a priority in multiple settings and will lead to more cohesive and effective treatment and generalization amongst clients and students alike.
When discussing the cons of collaboration in any setting, one may view this as difficult, as collaboration and teamwork seem to go hand in hand. And you might ask yourself what can be taken as negative when discussing collaboration. However, as we look into the details of what exactly it takes to engage in effective ABA collaboration, there are many barriers to address. To start off, on one barrier that should be highlighted, as stated in the opposing argument, adequate and frequent communication is required in order to ensure quality care is provided to clients. This effective level of communication is difficult to monitor and maintain long-term. As Bailey stated previously in the pro argument, the communication required can be argued as within the BACB Ethics Code. However, only outlines general code for behavior analysts to follow and is nonspecific to what actually is required daily to upkeep effective collaboration, leaving much room for error. It can be argued that this level of communication cannot be guaranteed to be upheld and meet standards of the BACB Ethics Code. As it is as highlighted in the opposing argument that different practices, OT, PT, etc., have different scope of practices and discuss the importance of remaining within these. However, we argue that the collaboration of these practices creates a crossover of competence that makes this particular barrier concerning. In 1.09 of the Ethics Code, it states all behavior analysts provide services, teach, and conduct research only within the boundaries of their competence, defined as being commensurate with their education, training, and supervised experience. While behavior analysts may only be providing interventions that are behavior analytic in nature, within collaboration, it begs the question of if there is a certain amount of crossover when working with the same clients that could cause both parties to step outside of their scope of competence. For example, when a client is receiving ABA direct therapy services and engages in aggression, based on the findings of a functional behavior assessment, the BCBA has determined the function is likely attention-based and has written a behavior intervention plan that gives lower to no attention to aggression, differentially reinforcing an alternative behavior, for example. However, a physical therapist who works with that same client believes that in order to decrease the behavior, compressions and sensory input need to be given. Thus, this is what she chooses as her treatment. This brings us to our last con. As behavior interventions are implemented by ABA professionals, the importance of treatment fidelity is vital. As stated in the BACB Ethics Code 2.09, the clients that we provide behavioral services to have a right to effective treatment. Collaboration with various professionals can and will put treatment fidelity into question due to the example I stated above, and should be evaluated frequently to adhere to the standard of effective treatment. And to address some ethics codes that are applicable for prior points made, 1.02, conforming with legal and professional requirements. Behavior analysts follow the law and requirements of their professional community, being the BACB, licensure board, And collaborating with other professionals may impede on our abilities as behavior analysts to act in accordance with what is required by our professional community. 1.05 Practicing within scope of competence. As behavior analysts, practice only within their identified scope of competence. They engage in professional activities in new areas that they become familiar with, different populations, new procedures, different levels of aggression maybe they're not familiar with, only after assessing and documenting appropriate study, training, supervised experience, consultation, and or co-treatment from professionals competent in the new area. Otherwise, they refer or transition services to an appropriate professional for that client's case. And as highlighted by previous visual and argumentative points, scopes of competence and practice may overlap. And the problem arises when collaborating professionals cannot create common goals for individuals due to their differences in their field, and this can't be identified, such as use of non evidence practice or differing implementation procedures. Lastly, according to the BACB Ethics Code in 2.14, when selecting, designing, and implementing a behavior change intervention, which we previously kind of touched on above, certain criteria must be followed, and the intervention must align with behavior principles. It must be backed by scientific evidence and represent results of assessments. Additionally, positive reinforcement must be utilized rather than punishment procedures first, as much as possible, and the plan needs best meets the needs of our clients and stakeholders. As previously discussed, while other professionals may use non evidence based interventions, it is a clear violation of the BACB Ethics Code, and this potential for violation puts a behavior analyst at risk professionally.
So that was our debate on professional collaboration. And provided on this slide here is our references. And thank you so much for watching and have a good evening.